Good morning, everyone. We're requesting everyone to take a seat. It's my absolute pleasure to welcome you to our 4th International Conference on Mental Health, Homelessness, and Inclusive Development in Chennai, where we've gathered today under the theme of Hope, Home, and Health. My name is Sangamitra Savadatti, for those of you who don't know me yet. I'm a Deputy Director at the Banyan Academy of Leadership in Mental Health, also known as BALM. The Banyan, founded in 1993, and BALM, founded in 2007, are sister concerns, and we work collectively and collaboratively on creating an inclusive, just, humane world by enabling access to comprehensive, integrated, person-centered mental health care for persons living in poverty and homelessness. We also passionately aim to bridge treatment and care gaps through research, social action and education, and build effective and ethical leadership in the mental health sector for vulnerable populations. To our esteemed participants joining us from across India and around the globe, we appreciate your presence. We're honored to host a very diverse group of professionals, researchers, academicians, practitioners, policymakers, and individuals with lived experience today. Your presence here celebrates the global unity and the shared vision we embody in addressing the work and challenges in front of us and showcasing the power of our collective wisdom, experience, and collaborative spirit to create meaningful change. Globally, an estimated 1.1 billion people experience homelessness, a majority from low and middle income countries. In India alone, the official figures suggest close to 1.77 million homeless individuals. It's important to note that these data for India are from 2011 census and likely to underestimate really the true scale of the problem based on limitations in data collection and the definitions used. So the dearth of data on those who are homeless is further compounded by the dearth of information available globally around homeless persons living with mental illness. Over the next few days, we'll continue to highlight issues pertaining to this vulnerable population. Our agenda is structured to generate conversations and thoughts around some of the most pressing issues at the intersection of mental health, homelessness, and inclusive development, particularly in the context of the Global South. We will also contrast and compare those experiences with similar endeavors in low-resource settings in the Global North. And as we explore some of these complex issues, we recognize that the current systemic resources and our approach to resolving them must evolve. We need to incorporate lived experiences, develop culturally responsive interventions, and forge strong, action-oriented public-private partnerships to create meaningful change. The Banyan's previous 3 international conferences focused on global voices of lived experiences and emerging trends in deinstitutionalization and long-term care. Over the next 3 days of this 4th international conference, we will engage in critical dialogues that bridge theory, practice, evidence, and experience related to the entire ecosystem of care, from outreach on the streets to housing and supportive services that are available for the individual through their life cycle. Day 1 of this international conference will focus on acute care and aftercare approaches, featuring symposia on care models from India to North America and Africa. We will dive deep into the ethical dilemmas and contestations in care, examine issues of choice, integrity, human rights, and post-discharge concerns in meeting the needs for care for this vulnerable population. On day 2, we will be shifting a lens to inclusive living options in the community. We'll hear experiential comparisons of long-term supported living from global partners and explore scaling up of innovative programs like the Banyan's Home Again that's operational across multiple states in India and in Bangladesh and Sri Lanka. We'll hear about the Housing First initiative that originated in the United States of America and the Trieste initiative from Italy. These will be followed by experiences and narratives from our Home Again implementation partners who we have here in Chennai, who are functional and operational across India and beyond, followed by critical discussions on sustainability and future directions that will help chart a collective path forward. Our final day offers a focused seminar on open dialogue, dialogical practices, and its application in crises by providing practical tools to enhance our work. We'll also launch a Global South and a Global North solidarity group to examine successful public-private partnership models in mental health care delivery, fostering collaboration and engagement across geographical boundaries. The depth and breadth of topics that we will explore over the next few days reflect the complex realities faced by those experiencing mental health challenges, homelessness, and social marginalization. We also want to emphasize today that this conference is for all, regardless of language background. While the main sessions will be conducted in English, we recognize that our work, content, and reach extend beyond any single language. We encourage you all to please engage in the language that you're most comfortable with. Translations are available in smaller groups, so please reach out to us if you require translations, and please do not hesitate to reach out for assistance. The sessions are being recorded as well, and we will ensure that subtitles are made part of the recordings. We want to make sure that everyone understands that the event really reflects the rich tapestry of diversity that is the Global South. While English serves as the common language for this gathering, we are committed to hosting events in the future with multiple languages to represent truly our global community. As we embark upon the discussions today, I want to mention a few housekeeping tips and rules. We kindly ask everyone to please silence their mobile phones or set them to vibrate mode. If you absolutely need to take a call, please walk out to the hallway to take your call. While we encourage active participation, we ask you to please refrain from any cross-talking during the presentations, because we've arranged for dedicated time around the presentations and the session, so you're able to meet one-on-one or in smaller groups to have those conversations. Another housekeeping update is that unfortunately, the morning session on implementation science on day 3 of the conference, which is July 25th, will not be held as scheduled. Our academic speaker for the session, Dr. Ramesh Raghavan from the New York University Silver School of Social Work, was unable to make it to Chennai because of the very tiny global glitch. That was the CrowdStrike software update that grounded very many flights across the world. We'll also miss Ms. Kali Silva, who's the CEO of Grand Challenges Canada, and Dr. Deborah Paget from the New York University Silver School of Social Work, who are also unable to be here in person. But for the implementation science session, we will be arranging with Dr. Ramesh Raghavan a time when he's able to be in Chennai, and we'll schedule a session with him so folks are able to attend, and we will make that announcement. We again thank you all for being here today. Your expertise, experiences, and perspectives are invaluable as we work together towards the creation of a more inclusive, diverse, and responsive mental health care system. Let us please all approach the next 3 days with open minds, compassionate hearts, and a shared commitment to our work. May our discussions be fruitful and our collaborations impactful. As we move along the agenda today, we're very happy to have with us Ms. Supriya Sahu, IAS, Additional Chief Secretary, Health and Family Welfare, the Government of Tamil Nadu. I request Ms. Sahu to please come up on stage. We also have with us Dr. Dave Henderson, Professor and Chair of Psychiatry at Boston University School of Medicine and the Chief of Psychiatry at Boston Medical Center. Dr. Henderson, if you please would like to come up on stage, we'd appreciate it. We also have with us Mr. N. Ram, the Director of the Hindu Group of Publishing Private Limited and the Trustee of the Banyan and a Trustee of the Asian College of Journalism, and really a journalist who needs no introduction. Mr. N. Ram, I welcome you on stage. I also invite the senior leadership from the Banyan, Dr. K.V. Kishore Kumar, Dr. Vandana Gopi Kumar, and Dr. Lakshmi Narasimhan to please join us on stage. Dr. Kishore, I welcome you to please make your presentation this morning to give us the history, the perspective, and the foundational values that have built the Banyan and the BALM over the past 30 years, followed by Dr. Lakshmi Narasimhan. Thank you.
Good morning, everybody. It is a great pleasure to be with you all this morning, talking about the story of the Banyan and how it has changed the ecosystem within the country with respect to the care for the homeless people in India. So the 30 years of journey has brought about very revolutionary changes within the country so as to influence politicians, administrators, general public, professionals to think of a way to support the most invisible population who live amidst us. So to start my presentation, I'm using a very simple definition of homelessness. Who is homeless? So obviously a person who doesn't have a home, a person who typically lives on the street, parks, sidewalks, abandoned buildings. He may or she may live in an emergency shelter, bus stations. Often they have very, very poor quality of life, and they have no access to the most important essentials for them to survive. As my colleague mentioned, that the proportion of people who are homeless globally is about 100 million, of which 1.77 million live in India, and close to 1 million are supposed to be living in the urban areas within the country. At best, this estimate is not appropriate because challenges in enumerating the homeless population is a tremendous task because of very rapid mobility of this population. Then lack of affordable housing is a very major contributory factor. The surveys that is done in India suggests that the range from the homeless population in urban locations range from about 20,000 to 2 lakhs across the country in 10 major cities. Poverty and mental health is an important nexus. Mental disorders contribute to about 13% of the global burden of disease. 80% of people live with mental illness die before reaching an average life expectancy. 80% of people with mental illness remain out of work due to disability associated stigma, discrimination. About 150 million Indians live with diagnosable mental health issues, but 83% remain out of care required to regain health. This is an important statistics that we cannot overlook at all. Access to mental health care continues to be low, largely concentrated across the monolithic mental hospitals, and that is the only source of support for them, which is often grossly inadequate. Poverty presents additional barriers to this scenario with greater risk for homelessness. The invisible narratives, as depicted in this particular slide, includes revolving between custodial institutions, streets, poor health, high rates of death, unfriendly public places, exclusion from citizenship, financial exclusion due to barriers in access, distance from social economic resources, lack of low kinship resources, out of stable work arrangements, and these are some of the sustaining factors which keeps people homeless and often result in very poor quality of life. What are their needs? Homeless people, homelessness is related to, as you know, very complex familial, social, economic, political, developmental, geographical difficulties. To add one important issue, development alone has resulted in erosion of close to 60,000 villages in the country since independence. Lack of housing, poor social supports, unemployment, lack of access to health care, inability to access social security, lack of access to legal aid, non-availability of low-cost housing, lack of people-friendly policing, and lack of an agency to register homelessness are some of the most important difficulties that needs to be addressed, and these are very, very critical aspects. They need medical care, acute psychiatric care. Often their medical conditions, comorbid health conditions are so poor that it is often seen that the random blood sugars may be about 700 and they don't even realize that their health is so poor. They may have gangrenes, non-healing ulcers, tuberculosis, malunited fractures, and so on and so forth. So often these are years-old problems which may not have been addressed. Rehabilitation, including vocational training, welfare benefits, sheltered workshops. When these people have not had access to care, occasional training or skill development is a far-off dream, and therefore all of these things becomes important. Registration, reintegration with family, supported housing, halfway homes, long-stay homes, homes for the elderly, group living, and foster care. Lastly, legal aid are some of the most important things. The resources that we have, as on today, we have about 804 districts, 43 mental hospitals in the country, more than 12,000 psychiatrists. There are 30 centers of excellence, which is the mental hospitals being converted into postgraduate teaching programs, and they have invested close to about 400 crores. There are 7,700 plus DMHP programs, 706 medical colleges, out of which 386 is in the government sector and the rest is in the private sector. Systemic resources for the homeless mentally ill is nil except mental hospitals. Among the first few initiatives was Udavam Karangal in Chennai, Missionaries of Charity, and later the Banyan in 1993. By far, the Banyan model has now become the model that is being embarked on within the country. So the models of care would include community-based model, institutional model, which is the mental hospital, and street medicine. Of course, we don't practice street medicine in the Banyan model. So the Banyan model is referred to as Emergency Care Recovery Center, is a service for the homeless persons with mental health issues. Admissions are largely voluntary. A few exceptions where persons with mental illness are admitted without explicit consent as a result of exacerbation of symptoms or extremely poor physical health. As I mentioned, it could be a malunited fracture, a gangrene, tuberculosis, or a person with HIV and its complications and so on. The Mental Health Act mandates a police officer to rescue people with mental health problems who are a danger to self and others and reach them to safety, which is not happening often. It is the public involvement and other people's involvement which is the most important thing. We are making an effort to see that that particular loop is strengthened. The care at the Banyan includes referrals based on information about the person from general public or a hotline. Care consists of attention to physical health problems to start with. Stabilization is absolutely important. This is followed by identification of existing mental health problems, providing appropriate care to them. Care occurs in home-like environment with importance given to freedom, expression, and varied opportunities to participate in activities of interest and choice. Focus on brief stays as possible, goal of the community inclusion and valued social roles. So the difference between an acute psychiatric facility and the Banyan is obviously visible from this particular slide, which entails that people's freedom, a right to make a choice, negotiate with the team whether I would require treatment right now or not, are some important elements which guarantees very rights-focused approach. This is the impact of the work that the Banyan has done, and the slide reflects the number of people who are admitted in the Emergency Care Recovery Center. Similarly, the number of people who live in the home again context, thanks to our partners who have been able to extend support for us. And it is important to recognize that without these partners' involvement, for example, ECRC partners would include MS Chalamuthu Trust, Research Foundation, Varai Foundation, Shed India, Rural Development Council, Nilgiris Adivasi Welfare Association, Achayam Trust, R. Soya, Benadora Foundation, Sri Prasanna Venkata Jalapati, Gunaseelam Trust based in Trichy is combining both spiritual healing as well as medical intervention. For home again, the partners would again include Menadora, Or Soya, RDC, Mehak, Maria Sadanam, Schizophrenia Awareness Association, Altruist, Green Dot, Jewels International, GSVS, Asha Deep, Mental Health Society of Jaffna, and Sajida Foundation. So the last two represents our international collaborations. Challenges in care, as we all know that all people who have, all professional groups who have worked with homeless population obviously know that there are many challenges. One of them is the issues of intersectionality, poverty, gender, and so on. Behavior disturbances associated with mental health problems. There could be a comorbid personality disorder that may exist, or it may be a problem related to brain damage or substance use. Severe comorbid conditions like tuberculosis, diabetes, broken bones, osteomyelitis, and so on. Intellectual disability, intractable mental health problems. For example, 30% of people who are on treatment may not respond to a particular intervention, and therefore that's a challenge. And the last of which is the language barrier that may exist in the context of a diverse country like India. Many challenges will exist in this particular domain.
Thank you, Dr. Kishore. Appreciate your time. Dr. Narasimhan from the Banyan, our senior leadership. Welcome.
Thank you, Dr. Kishore, for giving that background. What I'll be doing is giving a brief summary of the three major care approaches which the Banyan has engaged in over the last 30 years of work. And like Dr. Kishore said, this is no longer our body of work alone. There are so many partners working across different parts of India, as well as into low, medium income countries of Sri Lanka and Bangladesh, who are also working with the same population and building upon these approaches further. So this is the first Banyan program, a curriculum that started in 1993. At that point of time, when Vandana and Vaishnavi established this home for homeless women with mental health conditions in Chennai, I believe the thought was that there are probably about 20-30 people like this, and they will live lifelong in this home-like environment. But that was clearly not to be. Within a year, they had hit much higher numbers, double of what they had expected. And over a period of time, by 1996, they established a much larger facility, and which has now evolved into the Emergency Care and Recovery Center model that you see. So what the story of the Banyan's beginnings tell us? That, like Dr. Kishore said, a lot of homeless people with mental health conditions, why do they end up homeless in the first place? So one aspect of it, of course, is that they have a mental health condition and they move away from their families of origin. So that's just one part of the story. But a larger part of the story is the sort of social disadvantage, the kind of backgrounds that they come from, which push them into this periphery, and therefore they end up homeless. And not all of them are essentially willful abandonment. I think the general public imagination is that homeless people with mental health conditions end up this way because families willfully abandon them. Sometimes it could even be a choice where people are escaping sites of violence. Sometimes it could be abandonment in certain conditions. In certain conditions, it's just that they've not had the resources necessary to address that situation at hand. So that is something that emerges very prominently in the Banyan's story. So we increased capacities by 1996. Soon we had problems of long stay. So what is the emergency care and recovery center model, which Dr. Kishore also spoke about? Essentially, we call it a coordinated, collaborative, multidisciplinary care system. It's collaborative not just because there are different disciplines involved in the delivery of care, but because service users are centered over here. So lived experience of service users actually informs the form and shape in which you see the emergency care and recovery model today, including the sort of exit options that have been developed. So it's not just return to family. One could go to a place of employment and find living there. One could move into a hostel kind of facility. One could stay also in the institution in a different kind of a space if that is what one chose to do it. So truly the center of this model is the opportunity to receive unified care and to be able to determine the pathway as I choose for myself. So that's the Emergency Care and Recovery Center. So almost 4,000 people have received crisis intervention services, not just through the work of the Banyan, but the work of our partners. Significantly, this is a model which the National Health Mission of Tamil Nadu, Government of Tamil Nadu has integrated within the district hospitals itself. So as part of the public health system, the civil society organizations, NHM, with support of the Banyan, runs these facilities across these many different locations that you see in Tamil Nadu. The ones in red are direct sites for us. The ones which are marked in blue are sites which are essentially this emergency care and recovery center, but run within a public health context. And what we have found very interestingly in the last 3 years of doing this work is that the pathways into homelessness actually are very diverse across these different districts. So there is violence, relational breakdown, care or death, which perhaps precipitates crisis, but certain districts come with their own socio-economic, cultural variations. So caste may be a very significant issue, perhaps more in the southern districts of Tamil Nadu. So we see those sort of associated issues come up. So understanding these factors is something which is very important for us when we are considering homelessness prevention. What has also happened as a result of these efforts is that one thing that we've seen longitudinally in our data is that almost 70% of people who end up homeless and within the remit of these services are actually from Tamil Nadu itself. Of course, we have about 30% from the rest of India, but many of them are from within Tamil Nadu. What has happened as a result of these efforts is that because we've been able to provide proximal care within the district hospital setup, an inpatient setting combined with aftercare. So once a person has moved out of this facility, we are able to follow up on them. Our aftercare rate has improved. So we are able to consistently offer continued care for almost 70% of people who exit out of facilities now. Long-term care is something that is a persistent issue that emerges. So 6 in 10 exit facilities through various options. Some of them move into semi-institutional, institutional or hostel-like facilities, but we still have a significant number that will perhaps require some kind of living arrangements long-term in a community-based setting. And that brings us to Home Again. So Home Again essentially is a group of 4 or 5 people rent a home in the community. These are rented in ordinary neighborhoods where you or I would also rent a home. And they are provided different forms of personal assistance. And we have frontline staff who are trained as personal assistants who deliver it. And it's a varied range. So it's not just, so some people perhaps require assistance with their daily bathing, etc. But some people may perhaps just learn to, use transportation again. The world may have changed from the time that they have been in the institution for a very long period of time. So this is the Home Again model, and this again we've been able to work not just within our context, our partners have been able to work in their own context to also implement this model. We evaluated this in 3 different phases. The first 2 were non-randomized controlled trials, and the third one most recently concluded, where we took it to across 9 states plus 2 locations outside of India is what is most recently concluded. And my colleague will present more on this tomorrow. So we have about 125 homes, 600 plus people living at any point of time. 767 in total have accessed. And the interesting thing that we find is that after people come to home again, from an institution, they move into home again. From there, about 10% move back to their family. But again, another 10 to 12% actually say, I want to go back to the institution. So now we are also looking at, so what do people want? Because some people do not want to live in the gaze of the community, right? Some people want the comfort which may perhaps be there in the community that is there existing within the institution itself. So we are looking at hostel-like co-living spaces now. What we've also learned is that, so we did it in many different kinds of neighborhoods this time, and in high-income neighborhoods, we found that the acceptance was much harder to negotiate and get, whereas when you locate it within medium-income communities, it works very differently in terms of community integration. Again, a balance between keeping it too scattered, because scattering it too much perhaps made people feel like it was too isolated, to keeping it too clustered as well, where you are seen as, oh, this is the row where people with mental health conditions live. So those are some things which come up, which I think tomorrow will be talked on more in detail. But like I said, the most important thing that we've learned is that there's a persistence of both social causation and social drift in terms of maintaining this nexus between homelessness, mental health, and poverty. And which is why we feel that it's important to work on community-based models that reframe the whole approach to mental health conditions in terms of combining clinical interventions with sustained social entitlements through village-level alliances. So that's NALM. And in NALM, we again have grassroots workers who work in their own communities, in their own villages. NALM is something, again, that we are working now in different states. So we have already in Chennai and Chengalpet, we've been doing it for a while, but now we are expanding it through our partners in Madhya Pradesh and in Odisha. We also work in a location in Maharashtra with a predominantly Adivasi community. And over a period of time, because we have been running outpatient clinics for a long period of time, almost 10,000 people from low-income households have accessed care. This model also services our aftercare network, that is people who exit out of institutions and move out. So we also service them. A large focus is on reclaiming citizenship and political participation across low-income settings, those who are with histories of homelessness, those who are within institutional settings but require this kind of access. And one of the most important findings that we have had from this experience is that there are significant caste differences between people who have become homeless and those who have not. So among the people from the low-income families who access our services, if you see, one large part of it is, of course, relational disruptions, but we also see that among low-income families, who becomes homeless, who doesn't become homeless. So therefore, these structural factors are hugely implicated in homelessness itself. So it brings us in terms of what is it that we're looking at in terms of the bigger picture. So when we think about doing health system reform, a lot of the times the resources are applied towards infrastructure. Let's increase human resources. Let's look at facility-based strategies for improving access to care. But the plans need to actually focus on people and people-centered strategies, right? So one of the most important things that I would say we've learned from the Banyan is that how can health systems improve their adaptive capacity by listening and engaging in constant dialogue with the constituency in whose interests we are working. I think that's so important. And that representation is not just about we have a few people who are part of this dialogue. So I think that's one very important lesson. So in terms of knowledge production in health systems, we don't need to always look at it in terms of being driven or mediated by a traditional norm of who a professional expert is, but systems need to constantly respond through a process of dialogue that seeks lived experience, expertise for solutions. So that's one. As an extension, I think it's also important for health systems to consider what is it that we're measuring in terms of meaningful outcomes. So what is it that we're engaging in? So what do people consider as meaningful outcomes? And there's so many dialogues that we've had so far. These are not, let's reduce inpatient days, let's reduce dropout, let's make sure that people adhere to treatment plans, let's ensure that every incidence is enrolled into care. So it's not so much that, but when people walk into our services, they want to get back to their lives as it was before, and they want to work on their aspirations that they had at one point of time. So they really seek that reconnection back. They want to engage in social roles, they want to return to work, they want to have tangible social relationships. So that's a second implication. And the final implication is in terms of how structural violence shapes health problems and recovery trajectories. So Very often we find that when people have multiple jeopardies of this nature, the services are not integrated. Health functions completely different from social welfare, functions completely different from disability. So for a service user, they actually they have to prove their eligibility at multiple points of time. So it's very indignified in a way in which, I have to show that I am poor, I am suffering, I deserve this support. So you have to establish it at multiple disaggregated service point to simply get what their entitlement is. So I think truly to understand how the structural violence is shaping mental health problems and recovery trajectories, and offering that integrated syncretic service as people are entitled to, is something that I think we need to consider. With that, I'll conclude my presentation. Thank you very much.
Thank you, Dr. Narasimhan, for that history, the background, and the perspective. I invite Dr. Vandana Kumar, the co-founder of the Banyan and our visionary leader who started it all, to make a few comments.
Good morning, everybody. So I don't really have a presentation, but I have, because I think both between Dr. Kishore and Dr. Lakshmi Narasimhan, they've said everything that there is to about the Banyan. But I do have a set of questions and thoughts that I would like to leave with you, because we're going to spend the next 3 days together, and I think there's going to be great opportunity for us, therefore, to dialogue, debate, and arrive at perhaps at some solutions, or at least continue to engage in this conversation post the conference. So the first question that I have, and the first thought that I have, is linked to this very sacred binary position of the institution being juxtaposed with the community, and with one or the other being accorded higher status. So I think it's now time, really, because it's somewhat frustrating. We had, we have over the past 200 years engaged in this debate. We have in India itself a lot of data and a lot of scrutiny on how large total institutions have operated over now about 100 years. And from the Bhor Committee onwards to the National Human Rights Commission and reports, we don't have very encouraging feedback. And yet we continue to engage in this debate. So I think there is a need, therefore, for a shift in debate to understand what healing care spaces ought to look like beyond these binaries. Should there be decreased numbers? Is it personal attention? Is it the kind of human service professional? There is clearly a hierarchy within the mental health system. Should those hierarchies prevail? Should we flatten those hierarchies a little? So from being focused on large institutions to no institutions, should we transition into healing spaces such as the ones that we've now initiated with the National Health Mission, which are integrated within the public health system, which only accommodate about 25 people. There is personal attention, there are person-centered goals, and there is a multidisciplinary team where social determinants and post-discharge care is focused. So can the debate shift a little? And can we then look at reforms? Because really 100 years, or even longer, maybe 200 years of discussing confinement is, I think, sufficient. My second broad point is the long-term care issue. Somehow we behave like we have this ostrich sort of mentality where we pretend that this is not going to be an outcome, even the Banyan. And when I say we, I begin with us at the Banyan, right? So therefore, in relation to point one, we have experienced ourselves the damages associated with a total institution. When like Lakshmi mentioned, we were at 100, but when we got to a 400, we saw care slip. We have some of the peer advocates seated over here who spoke about disruptions in care and loss of dignity when a very burdened human service professional responded with apathy and sometimes even with aggression. So I'm therefore speaking from laying bare our experience and speaking from the Banyan experience and not so much pointing fingers at state institutions. That's in the context of the first. But in the context of the second, we've seen clearly that there is a largish number that's going to be requiring long-term care. Now, what happens to them? We do have the notion of rehab homes across the country, but merely referring to a center as a rehab home doesn't make it any different from an institution. Therefore, what exactly do we mean when we refer to an institution as a rehab home? Should there be a better social audit system that looks into what these homes stand for as symbols and what services these homes provide? Is community inclusion, work participation the goal? Or are similar sorts of segregation that one experiences in total institutions or mental hospitals also prevalent in rehab homes, just with a different name? Therefore, social mixing not being promoted in a rehab home, or even for that matter in a home again? Now, an institution, even the model that we spoke about, home again, can at times turn into an institution, even if it is just 4 or 5 people. But if the care approach or if the philosophical underpinnings aren't sort of rooted in a culture of social mixing, of participation, of free expression, right? Or of embracing neurodiversity. So when we speak rehab homes, do we just speak the structure, or do we also speak about the culture of care? So if we could, over the next couple of days, speak about what really rehab means, what culture of care means, and these are not problems that are unique to India, these are global problems. So homeless people with mental health issues who experience the sort of distress that they do here, that Dr. Kishore and Dr. Narasimhan have outlined, is exactly the same in the US, and sometimes even worse, because many of them are on the 9th floor of prisons, right? As a result of being able to access care only when they are, they are sort of in conflict with law. Okay, so from there I move to my third point, which is social determinants, which has largely been clustered as a huge monolith. And we have papers and data and a lot of rehashed literature over, again, a 60, 80-year period where we focus on structural barriers and systemic barriers and violence associated with caste-based, gender-based, class-based differences, especially relative poverty. We were sitting in a group, amongst a group of mental health service users, peer advocates, and care providers, and one of the ladies, just day before, and one of the ladies there turned to us and said, I have been working since the age of 13. I lost my parents early. I was married to a very good man, and I had great support from my partner. He took very good care of me, but then he passed. And after he passed, I was left alone and had to take to a job. And take to a job again. And when I did, I found a lot of satisfaction. And today I have an income of 1,20,000 rupees annually. So that is about 10,000 rupees a month. And then she said, on television, I've been watching these videos of recent events where I'm seeing a lot of monies being splurged in crores. So the experience of relative poverty, of me in context of the larger social system, and why is my lot as miserable as it is when there is this 1% that lives with access to resources the way that it is. We have spoken about the impact of relative poverty on mental well-being. We have spoken about many other social determinants, many other systemic barriers. But what really have we done about it? Is caste going to disappear? Are the class differences going to be bridged? Well, these are difficult thoughts and sometimes intractable problems. So how are we going to get past that? Redistributive justice? Affirmative action of what sort? The chief minister's allowance of 1,000 rupees certainly is something that people seek. The out-of-wage allowance or the disability allowance that people refer to as I prefer to refer to it as an out-of-wage allowance because it sort of makes it a little more permanent in the context of abject poverty. What happens with this 1,000 rupees and how much does it serve that person? Should that increase? Should we head towards basic income for those who aren't employed or don't participate in the workforce? That's my third question. I have just two more. The fourth, we spoke about research. In the context of research, I think all of us sometimes are not able to put our basic nature behind, which is really to protect and preserve our institution and our own personal interests, and therefore speak about our models and speak about a model being taken to scale and speak about the efficacy of the model. And in that context, cling on to it, spread a lot of information about it, and sort of be driven very strongly by the ideology and the flavor of that model. I think it takes a lot, but it's important for us to discuss ways in which I don't think it's about one model versus the other, but about multiple care approaches. And I think for a problem as complex as this, one needs to synthesize and bring together all these care approaches and look at ways in which the diversity of these approaches can service that individual, which is what Lakshmi really spoke about. But we continue to talk about Home Again being scaled up and ECRC being scaled up, which at some level is important because we can't move away from a pragmatic space. But as much as we do that, or talk about the Trieste experience, or Housing First, or open dialogue, but as much as we do that, equally, there has to be a sense of openness to embrace different care approaches that work. Because what works is what is essential. And therefore, as much as you highlight the model and its and good practices that emerge from it, equally please highlight the challenges and realize that there is no one model that serves all. And if we could just become a tad model agnostic. Finally, I think the last 2 points that I have is, can there be a platform such as this that focuses on severe mental illness and homelessness, because it's so smothered with such sort of complex interplays and interactions. And therefore, we need to sort of problematize or sort of complicate the narrative. And in doing so, can we just discuss with a sense of honesty, mixed groups discussing with a sense of honesty, things that we are not comfortable speaking about, like what I mentioned about Home Again, for example. Let's say that's a great model, and there are 700 people who now are living great lives. There are very few walkouts, but in some cases, the care providers, even in just this limited context of 4 or 5 people, have gotten frustrated, and there have been sort of bouts of aggression on the part of the care provider, and some have been subtle and covert, but some have been over the top, and which we have been quite shaken up about. And this is, again, human nature. Therefore, there is no saying when this could occur. So could there be a safe space and a platform where a climate of fear isn't cultivated, instead a climate of attempting to speak about these things as openly as we can, and knowing that we have to audit our systems, and therefore bringing the two together so there is open dialogue amongst diverse stakeholders of aggression, oppression, violence, inequities, hierarchies that could exist in a small place such as Home Again or in total institutions. I think this platform is absolutely necessary to advance mental health sciences. And the last point that I have is that we speak a lot about co-production, but I think in the context of mental health professionals or in any other context, it's largely tokenistic at many levels. The first level is just from a pedagogical point of view. I think most of the training is provided for care providers. And I somehow feel that the line should blur a little and that the training should be provided collaboratively for care providers and service users, so that beginning then, the lines sort of blur and people are exposed to themes and topics that are actually universal rights and should be their rights as well. So if the pedagogy associated with training mental health care providers or professionals can blur lines a little, I think that would help. But also co-production from a tokenistic point of view in the global north, or in reforms and legislations that we have spoken about, that drive policies and care plans. Who is it who finds a seat at the table? It's usually people from the global north, a person such as myself or yourself, some of you from the global south who can speak in English, who are from a certain class. I still don't hear the voices of people that we serve. We will have many of them speaking over the next couple of days with translations, but we don't have those voices. And sometimes the attitude is patronizing. So you have reforms largely driven by ideologies and ecosystems that are prevalent in the global north. And I think it's time now for the global south to come together as a whole and to represent its views and perspectives and ensure greater representation. I'll just end with this, but I want to quickly say that we are meeting after a fairly long time as a group, and it's lovely to see familiar faces. We did have a conference in between, but somehow it feels like that wasn't, like the previous conferences. So I want to sort of mention that we miss 3 or 4 individuals who are now not in our midst. One is, of course, Keshav Desiraju, who was the architect of the mental health policy, and he was a trustee of the Banyan and many other organizations, and he is deeply, deeply missed. Then there's my guide, my PhD guide, Professor Parshuraman, the former director of the Tata Institute of Social Sciences, who would have been a very active participant in today. He is missed, definitely. There's Jerome from the Azim Premji Foundation, who was a very engaged partner, philanthropic partner. He's missed. And most recently, the loss of Bhargavi Davar, who was an activist. We disagreed on many things. We argued bitterly, didn't speak for months on end. But I think there was a lot of mutual respect and love. And her passing was really recent. And she's missed. And I think as a tribute to many of them and to the people with lived experience, we owe ourselves and them a platform where these questions and many more that you may raise ought to be discussed. Thank you.
Thank you, Vandana, for really setting the stage for the next few days, for the questions we must be asking ourselves and each other as we really move forward to working with the populations that we serve and the kind of work that we do and we must do. I now welcome Ms. Supriya Sahu, who is with us today to inaugurate the conference. Ms. Sahu is the Additional Chief Secretary, Health and Family Welfare of the Government of Tamil Nadu. She's worked extensively in areas relating to socio-economic development administration, health, empowerment, environment, climate change, forests and media at various leadership levels nationally and in the Government of Tamil Nadu. Ms. Sahu, welcome.
Thank you, Vandana and Banyan team, for this opportunity, which brings me beautiful memories of our collaboration, I think way back in 2004. So it's like 20 years that I'm back here again. Ladies and gentlemen, good morning. Mental health care and homelessness is an area which holds a great significance. As we all know, significance not only for India, but for the entire world, and significance not only for the health sector or the social sector, but for the humanity. And when Tamil Nadu collaborates with Banyan through the emergency care and recovery center model, and so many other models of care, especially in the field of mental health, I think the world will do tomorrow what Tamil Nadu is doing today. I was reading a bit because I was out of the sector for quite some time, and it brought me again back to those beautiful memories where I realized that India's Mental Health Care Act 2017 is a fine piece of legislation, even though it may have some gaps. But it is truly ahead of its times, because it not only provides a legally binding right to mental health care to more than 1 billion people in India, in compliance with the Convention on the Rights of Persons with Disabilities, but what it does that it sets the entire country towards achieving the Sustainable Development Goal, which is SDG 3, which is the good health and well-being. And further, the most important and, the astonishing thing is that the act and the rules which were framed thereafter, they actually set gold standards for the public health system as to how the mental health care should be provided. And it is really interesting, and those who have not read it, I would request you to kindly read that in detail. It says that the mental health care has to be of affordable cost, of good quality, sufficiently available. It should be accessible geographically. It talks to those details. It should be without discrimination. Vandana spoke about it extensively. And it should be provided in a manner that is acceptable to the person who is mentally ill, or acceptable to the family or the caregivers. So that is why I said that this is truly ahead of its times. Those days itself, it described the concept of halfway homes, hospital and community-based rehabilitation, and how the care has to be slowly merged with the community care. I truly believe that government has a critical role to play in ensuring the rights of people who are facing the double whammy of mental illness and homelessness. And that's why I'm so happy to be here today to listen to all the suggestions and the outcome of the discussion. Why this is very important is because a good mental health care setup, and I'm talking, from the government context, it will require sufficient budgetary allocation. You like it or not, you have to have sufficient budget allocated for mental health care programs. It should have a well-functioning, robust healthcare system. These are all very important pillars of a mental health care program that we are talking about. It should have sensitive, committed, and above all, well-trained health force. It will require a multidisciplinary approach from various departments of the government have to work together, whether it is social welfare. Within the health system, various departments of the health system, they have to work together. And above all, it will require a beautiful collaboration with organizations and communities. Because then, and in that setting only, you will be able to break this vicious circle of mental health, illness, homelessness, which is associated with vulnerability and poverty and all the other trappings that you spoke about, Vandana. Now, Tamil Nadu State Mental Health Authority, just a little bit as to what is it that we are doing. As a state, it is very important, as many people mentioned before me also, to look at every aspect of the healthcare that is being provided and how it is focused and how it is inclusive to take care of the mental health and mental illness challenges. So Tamil Nadu State Mental Health Authority, just a bit of information, so far has registered about 692 mental health establishments in Tamil Nadu, and we are operating the district mental health program in all the 38 districts in Tamil Nadu. The Institute of Mental Health, which is at Chennai, is one of the oldest and premier institutes in India, which is actually the apex body to provide care to mentally ill patients. And I was talking to the director, Malayappan, and he was telling me that every year about 5,000 patients are being brought to the institute by families. 80% to 90% of them are brought by families, and a large number of these patients, they become all right, they go back to the family settings. But he also mentioned that almost every day, 2 to 3 patients who are wandering and they are homeless, they are being brought to the institute from Chennai or from the other parts of Tamil Nadu, and they have also started working on integration and bringing these patients back or taking the patients back to the family. And he was saying that in the last year itself, which is 23-24, if you say this last year, about 225 patients, the government institute has been able to successfully reunite and reintegrate within families. And I think that is something which is giving us hope and something which is inspiring, and it can be followed up. I also would like to mention here that in this entire setup, I think the mental health program perhaps now need to reach out to the village level too. The time has come that where the institutes which are actually located only in urban areas or in metro cities, the model that Banyan is taking now to the ECRC model, I think it's time that we talk to the Panchayati Raj institutions also. We see to it that the institutions at the village level, at a small, in a pilot, we can kind of start talking to the village Panchayat units and see to it as to what concepts and ideas they have. And that perhaps maybe, there could be an answer, the questions that you were asking, to what extent we can go on actually building institutions or looking at communities or looking at whether this model is good or that model is good. So I think that for me, we need to keep trying. But I think the time has come with all these experiments and with all these models that we now talk to the Panchayati Raj institutions also and see to it as to what ideas and solutions they are suggesting. ECRCs, the model that Banyan has brought under the National Health Mission in Tamil Nadu, we are now operating in 17 districts. In 8 districts, which is in Ranipet, in Kallakurchi, Theni, etc., in 8 districts it is being run by the Department of Health, and in 9 places we run with Banyan and other NGOs. And they really are models which should be looked at because they provide the bedded facilities for any kind of an inpatient care, equipped with psychiatrists, psychologists, social workers, staff nurses who are providing care and treatment. And it was really something which was kind of heartwarming. A couple of days back, the Dharmapuri Medical College, where an ECRC is functioning, informed us about this 30-year-old young person who had been facing mental illness for quite some time and was brought to ECRC and was under treatment, and they told us that it was so difficult to manage because of the aggressive behavior, the violent behavior, but they did not lose hope. The person also escaped twice from the institution, but the staff of the ECRC went out, brought the person back, the young man back, treated, and most importantly, they established a beautiful communication with this young person. And I think after a hard work of 4 months, they successfully reunited this young person with his family. And I'm so happy to see that from a public health, from a government setup, if these examples are coming out, I don't think we need to be feeling disappointed at all. And I would like to thank Banyan, Vandana, and the entire team for bringing out something which government institutions can do. But perhaps they needed to know as to how it needs to be done. They needed to understand that it needs to be done, and they needed to know that it is their responsibility and it is their duty to do. And it has to be done for the right of that person. So, lastly, I would like to say, in summary, what I have understood because of my tenure earlier and couple of weeks that I spent in this job, I truly believe that there is a time now to reimagine the mental health care services in our country with a focus on few things. And this is after I have had discussions with my team. Cutting edge medical science treatment. I think we cannot deny that this is absolutely essential. But how it is to be provided? To be provided in a multidisciplinary and collaborative approach. Integrated care, and I think the time has come when the ECRC's model can be taken to all health institutions, perhaps to the country. Closing the gaps and joining the dots is something I think we must be doing now in the government setup, so that the model that we provide is a sustainable model of healthcare. And lastly, the path-breaking policy, which is the Tamil Nadu state policy for care of homeless persons with mental illness 2024, which is in the offing, being developed in partnership with Banyan and other government departments and agencies, would certainly be a torch bearer and would lay an excellent foundation for the mental health care in the state of Tamil Nadu and perhaps for the country and the world. Nandri, Vanakkam.
Thank you, Ms. Sahu. Really appreciate your time here this morning, giving us a perspective of what the government of Tamil Nadu is doing, what we can do together, and what's to come in the future. And it's very energizing to have you here this morning. So thank you very much. I now invite Dr. David Henderson to speak to us today. Dr. David Henderson is Professor and Chair of Psychiatry at the Boston University School of Medicine and Chief of Psychiatry at the Boston Medical Center. He will continue on with the symposium to speak on homelessness and severe mental illness and care approaches. Boston University and the Banyan and BALM have had worked together for close to a decade now. So Dr. Henderson is an old friend and collaborator of the Banyan and BALM and has provided support and research supervision for many of our studies, specifically research supervision via the Boston University Foundation India and the BALM grant that we received in 2018 to study specific experiences of trauma and notions of trauma for homeless persons with mental illness. He has worked internationally for the past 30 years in low resource settings and areas impacted by mass violence, disasters, and complex emergencies. Please welcome Dr. David Henderson.
Good morning, everyone. Hello, you there? Good morning. Thank you. It's great to be here. It's great to be back. It's always nice when you're invited again to a place. That means you didn't like screw up or anything. So I guess I haven't screwed up too much. So anyway, so I'm going to go through a few slides and raise some topics, and I think hopefully we'll have time for a discussion. But I think for me, experiencing the Banyan has had a significant impact on my career and kind of decisions I've made and the way I think about care of people and getting them well and so on. And I'm a psychiatrist and psychopharmacologist, and we focused on the drugs and reducing symptoms and getting trying to get good outcomes with that, and leaving out a whole world of things that impact patients' lives and that impact their quality of life. And the Banyan, every time I come here, it kind of opens my eyes even more about what we should be doing and to get people well. So I'm going to talk a little bit about that. So this is just a picture from the previous work. And we did a little comparative study between Boston and Chennai. And one example is why these cross-country interactions and so on are so valuable, is that we looked at data at both places. And one of the questions I had was like, what are the medical comorbidities that patients in Chennai with mental illness deal with, and homeless patients and our patients in Boston, and they're actually quite different. Where in Chennai it was a lot of vitamin deficiencies and things like that. I think connected to nutrition. And in Boston it was diabetes, cardiovascular disease, like also connected to diet, but in a very, very different way. So anyway, these interactions are valuable, but it also reminds me that how important the research is in all aspects of what we do. And this is what I'm most impressed with the Banyan about. They're doing this amazing work, but they're also studying it. And a lot of organizations do amazing work, but they never study it. Or they write a report and say, people liked it, and can you give us more funding? But the Banyan is actually looking at the data, making changes based on the data, and improving their outcomes and so on. And it's pretty impressive. And that's one thing that I've always focused on in my career. Let the data help us do better with our patients. Now, in my hospital, back in 2015, I switched hospitals. Before I was at Mass General Hospital and Harvard Medical School, and I switched to Boston Medical Center and Boston University School of Medicine. And the differences between those two groups was the patient population. At Massachusetts General Hospital, the patient population was 95% white. At Boston Medical Center, the patient population was 70% non-white. Dramatically different, but also what we call the social determinants of health, dramatically different. So at Mass General, I could just focus on the drugs and the psychopharm and reducing symptoms and so on. But when I moved to Boston Medical Center, it was everything. We had to get housing and food insecurity and employment and poverty, like all of those things, and we had to do it in the same visit. And so it really, really brought out, some considerable challenges, and we started to look at our data and saw tremendous health inequities, basically. Even within our own hospital, while we should be treating everybody well, turns out we were not, and that's why you have to look at the data to understand what you're doing and what the outcomes are. And so we started to take a closer look, and then even like looking at our Black patients, we started to understand what are those things that are contributing to poorer outcomes, and we identified a whole bunch of areas, and not just in mental health, but in cardiovascular disease and OB, pregnancy, and so on, where the outcomes were much worse in our Black patients. Yet we've been taking care of Black patients for 100-something years. So how is that possible? So we really needed the data to try to understand it and start to fill in all of the challenges, and that's important. And then the COVID-19, of course, just totally exposed our problems in equity. And our Black patients suffered far greater and higher hospitalization rates. Of course, they were in jobs where they couldn't work remotely, like a lot of people were able to work remotely and so on. So higher exposure rate. And then, of course, our homeless patients were, it was even greater, the risk and so on. To the point where, we had to start to really think about all that we do. And so we, as a hospital, decided that everything we do, it's going to be with an equity lens. We're going to look at, in every department, we're going to look at the data, and we're going to make sure that across patients, and when I say 70% non-white, it's also patients coming from 70 different countries every day. So it's an extremely diverse group of individuals, but we had to get them to the same outcome. And so we recognized that we had to not only do a lot of partnerships within the community and expand that, but we also had to do the research, develop the programs, and so on, and start to think out of the box. Like we're a healthcare system, and we're supposed to take care of sick people, right? You come into the hospital, we're like, oh yeah, you're sick, we're going to help you, and then we get paid to do that, right? But we had to start to think out of the box, and this is what comes back to the Banyan, and we came to the conclusion, and my experience with the Banyan really helped push the system to answer the question. The CEO came to me and said, do we need to get into housing? And I'm thinking about the Banyan. I said, absolutely, like, we need to do that yesterday. And so we set about getting into housing, like a hospital doing housing. And it turned out it was a critical piece to improving health outcomes. We had to get people housing, just a basic thing. And one of the other things that I want to point out, like with the Banyan model, the home again, all this stuff, you got a lot of stuff there. The Banyan model, it actually addresses one thing that every time I go to a psychiatric meeting, and with all the experts and stuff, and they say, yes, but we are unable to figure out how to help patients with loneliness. And I'm thinking, the Banyan's been doing that. That model it's absolutely brilliant. If the person can't go back to their own family to develop a new family cluster, it's absolutely brilliant. So you could make a lot of money just saying we got the cure for loneliness, because all over in the scientific community, people are baffled. Like, how do we help patients with loneliness? And I can say within my own patients, it's a very significant issue. And in the U.S. model of we can get you housing, that means that we get you an apartment, and then you go to your appointments. But for the other, like 23 hours and 30 minutes, what do? And you're often isolated and so on. So we're starting to think about how do we adapt some of the Banyan approaches as we're building our housing programs. The healthcare have to address food insecurities. And this is one of those partnerships that we worked with a couple of local chefs, and we opened up a market right in the community to like healthy food, low-cost food, using local produce. People in the community work there in the market, and so on. And this is in combination with we have a food bank. As a doctor, I could just, send an order, and the person can go down to the food bank and get, food for a week or two for the family, with specific instructions, like low salt, low cholesterol, that sort of stuff. And they also have like a demonstration clinic or a kitchen to help people learn how to cook the meals and so on. So we have to address food insecurity. It's a critical thing. And then as part of that process, a few years ago we had opened up a rooftop garden, and now we've just opened up our second, and we're not only providing food for our patients, we're also producing enough for the community itself, and contributing to the community. So it's actually really cool. But these things, can be done, and we have to think about this as part of healthcare, not some isolated thing. This is a part of tackling those social determinants of health. This just highlights a bunch of the inequities, differential outcomes in infant mortality and diabetes and even suicide attempts. Really important to address. And so we have to address the homelessness, particularly in our Black patients. And then we have an area in Boston called Mass and Cass. And basically, for all the like opioid drugs like heroin, fentanyl, and so on that come in through the United States, they actually come in through this corner in Boston called Mass and Cass, and that's exactly where the hospital sits. And so you can imagine on any given day, there's just multiple overdoses, and there's hundreds of people who have just injected themselves and staggering in the street and that sort of stuff. And so we finally worked with the city, and particularly during when COVID hit, we had to get people, protect people, and so we developed transitional housing, temporary, and now moved on to more traditional housing. But in that housing, we have to deliver health care like physical, mental health, substance use care. We have to give them opportunities for employment. We have to be thinking about their own wealth attainment and that sort of stuff. So we really have to be much more of a comprehensive program. Now, we also opened up our own psychiatric hospital because hospitals were less, if you had a patient in the emergency room who needed a psychiatric hospital, hospitals around the city and the region were less likely to take somebody if they're a person of color, if they were homeless, or and so on. There are very specific demographics. And so we opened up our own hospital in order to take care of this patient population because nobody else was doing it. And what's special about this place is just is that it's zero emissions. Like we do solar, for energy, and then geothermal for heating and cooling, and so it's self-running. We save a lot of money, and I'm amazed that other places are not doing and utilizing this sort of technology. So, as I said, we established this goal for the hospital that everything that we do is with a health equity lens, and it really we had to transform the hospital in order to, because it requires data and looking at data, and it's just most clinicians in the hospital focused on the clinical care. They weren't researchers and so on, but we really had to transform the whole institution to use the data, and the data influence policy. And I'm going to give you an example of how we used our data to build programs and so on. Now, in this last segment, I'm just going to talk about, we went through decades ago deinstitutionalization of mental illness in the United States, decades ago, and we failed miserably at it. As it turns out, the criminal justice system became our largest mental health system. So instead of people, like I saw, the data, 37% are in the hospital for a year or more. It's less than 1% in the United States. But if you count how many people are in jail for a year or more, then it's probably at 20-25% and so on. So the criminal justice system became our mental health system, with of course not great outcomes. And I think we're gonna hear more about this with our speaker later today or tomorrow. Providing mental health care in the jail system, it varies city to city, state to state, region to region as to the quality. So it's important to recognize that. So the numbers are pretty high, and it's comorbid with substance use, very high. And then there's a number of factors that I'm not going to spend a lot of time going into, but number of factors that are contributing to this problem, and there are multiple systems, but that also means there are multiple places for interventions. I think a lot of programs will do one intervention and, maybe move the bar a little bit. But it turns out you really have to hit multiple places, multiple points in order to change this system. Data such as detaining low-risk defendants, even for just a few days, is strongly correlated with higher rates of new criminal activity. I did a study many years ago looking at this and related to clozapine for schizophrenia, and found that most of the arrests were like very minor stuff. Like I once had a patient who had schizophrenia. This is when I worked at MIT, there was a police officer on Mass Ave conducting traffic, and my patient with schizophrenia walked up behind the police officer and kicked him in the butt. I don't know why the patient did it, but it didn't lead to a good outcome. So he got arrested for something so minor and obviously related to his illness. But anyway, a lot of times it's just really very minor stuff. Let me just so systems level, first is, how do we prevent or reduce the number of patients with mental illness booked into jails? And if they're booked into jails, how do we shorten it? And then, how do we increase the connection for treatment for folks, particularly as they're coming out, and how do we prevent them from coming back in? And so people have seen pictures like this, and this is not an unusual picture. This is somebody with mental illness. I think the patient had schizophrenia or bipolar disorder. And I had never known of this practice, but they put a bag over the gentleman's head so that, I guess, to stop him from screaming or something. I don't know. But tragically, this gentleman died. And so this is, typical treatment. And this is another case in Philadelphia. A gentleman with bipolar disorder had a knife. This was the second time the police had visited him that day, called by the family. And, they're feet away, several feet away, but they still shot him, feeling threatened and so on. And then also this is around the George Floyd stuff. And I, people were calling me like, Dave, what do we do? With this, around this George Floyd stuff, what can we do to help and stuff? And I'm thinking, why the hell are you calling me? I have no idea. Tell the police to stop doing this, right? We can start with that. But what, then several days later, I woke up in the middle of the night, 3 a.m, and that's probably where I have my best ideas, I guess. And I woke up and said, wait a minute. I know what we can do, because we're already involved in all of these systems. And I'm going to describe very briefly in the next couple of minutes that we're already in there. And so we just have to change what we do. We just have to give the police and the judges and the schools and so on different tools to make different decisions. And this was solidified to me because I was, around the same time, I was in the parking lot of a supermarket, and there was a police car that had stopped a young white male, probably about 20 yards away from me, and searching this car. And he had obviously called for backup. So another police car came into the parking lot. And he had a direct line to where the police car was, and this young man, and that's had a direct line, but somehow saw me as a African American putting groceries in my car, and turned, deviated, and pulled up right next to my car. And I thought to myself, how powerful is this? Like in this man's brain, to ignore a 3-ton car with lights flashing, right? To ignore that, but then to see a black male, then that becomes the danger. And I thought, wow, we have to give them different tools. And you can imagine what it's like for our patients and our homeless patients on the street and so on, and how they respond. And so, as it turns out, we've had this program at Boston Medical Center called the Boston Emergency Services Program. And this is like our mobile crisis unit. We've been doing it now for 25 years. We've got probably 120,000 lives intervened on, many of them multiple times. And so that's how the program started. And then it evolved into, we need help with the court. So we opened up a mental health court, mental health and substance use court. So many of the patients who are arrested with mental health will go through this court, and we have clinicians there, full-time, they're evaluated, and we try to prevent arrests and get patients connected to treatment. And then we piloted working with the police themselves. And so we started out with 3 clinicians, and the police could call, and they would ride along with the police in order to, if there's a call and they think there's somebody with mental illness and so on. And then as a result of the data that we produced from that, it turns out that we reduced arrest rates by 75%. The city of Boston funded us for another 20 clinicians so that we cover every precinct in Boston. Every police precinct has the opportunity to have a clinician ride with the police and then help change the outcome. And then we started looking at the schools. It turns out the schools were calling the police on the kids. And so, particularly the young black males and so on. And so they're brought, police bringing the kids into the emergency room. So we started working with the schools. And then we realized that, we need to do something for people coming out. And the data showed that if we lose them, they're back in. So we developed an outpatient-assisted treatment. Folks coming out of jail, they get connected to our program immediately. We get the mental health care, and then we start working on the social determinants as well. And then, so this was all working, pretty well. But I thought, we should bring our multicultural approach to everything that we do. So we were, in all of these settings, we were doing trainings and stuff, but we weren't doing the right training. So we started to bring in multicultural experts to get, start to move the bar a little bit so that it gives people different tools as they make their decisions. And then we still had this problem, though, of our patients in jails, because they get there, they don't receive good care, they come out, our medicines change, all sorts of stuff. So we finally have done the final piece for now, which is to, we're now opening up a clinic in the jails. And so we're actually providing the care and then connecting them to care. So we're really trying to close, all of those gaps and get